The following program does not offer personal medical advice. Please consult your doctor before using any treatment or product we cover. Welcome to Go to Health Media with your host, Jonathan Marks. We provide a welcoming environment where experts educate you on important health topics, answer your questions, and provide information from which you can benefit in consultation with your doctor. You can visit and subscribe to the show at gotohealthmedia.com. And now, here is Jonathan Marks. Hello, everyone. This is Jonathan Marks. Welcome back to another show. We're so glad to have you here. Remember, you can subscribe to us at gotohealthmedia.com so you don't miss a show. You can also watch us on YouTube, and you can listen to us on 8 podcast networks. So the title of today's show is What We Learned from COVID That Can Improve During the Next Pandemic. So stay tuned. So researchers are already analyzing how the United States government and state health departments reacted to the spread of the COVID pandemic. This so we can improve response next time, and yes, there will be a next time. The Journal for Research in the Health Sciences and other publications have concluded that pandemics are getting more frequent and more severe. Why? Because people are traveling more worldwide. We have increased urbanization in many countries. We have deforestation and climate change, which are fueling new changes in animal and microbe interactions, and animal and people interactions, where pathogens are jumping barriers among species more often. A final aspect of disease spread is a shortage of healthcare workers and researchers. This is exacerbated by the recent shutdown of government agency websites, research funds, and reductions in staff. With us to talk about this today is Emilia Simeonova, PhD. She's a professor at Johns Hopkins Carey Business School. Dr. Simeonova's research interests are in the economics of health delivery, patient adherence to therapy, and the interaction between physicians and patients, racial disparities in health outcomes, the long-term effects of shocks to children's health, and the intergenerational transmission of health. She recently co-authored a paper called Staggered Health Policy Adoption: Spillover Effects and Their Implications, detailing how our government has responded to the spread of COVID with lockdowns and closings, and how we might deal with it better and differently next time. You can learn more at her website, which is emiliasimeonova.com. I'll spell that. It's Emilia, Emilia, Simeonova, Simeonova, emiliasimeonova.com. So welcome to the show, Emilia Simeonova. Dr. Simeonova, how are you today?
I'm doing fine, Jonathan, and thank you so much for having me over, for inviting me. I look forward to a great conversation. How are you?
Good, I'm great. Thank you for being here. So my first question, during COVID, federal and state governments closed down institutions, businesses, schools, and passed masking requirements or recommendations. These practices were highly criticized as being too much or too soon or too long, but also not fast enough. So how did we do as a country in holding back the COVID pandemic, would you say?
Well, it's a great question, and I think it's a question that we still need to properly answer. I think we need a lot more research on what happened and what worked and what didn't work so well. And I think somehow as society and also scientists, we have sort of moved past COVID. Everyone just seems to want to forget it.
Yeah.
But there's so many lessons from that experience that we still need to highlight and sort of put up front center for any policymaker or even historians in the future to mull over. Now, as a country, I think we do have some answers about how well we did as a country, and those would have to be taken in an international context because it was a global epidemic, and so that's a pandemic. So everybody was affected one way or another. You probably remember we were all checking out the Johns Hopkins coronavirus resource page. It was a fantastic resource. It was great service to the Johns Hopkins community, but to the world in general, where Johns Hopkins scientists were updating every day how many cases we have, how many deaths, what's going on with the pandemic. And I looked it up, and there's two numbers that I think we need to keep in mind, and that health scientists and doctors probably look at. One is, what's the mortality rate per 100 cases, per 1,000 cases. And our mortality rate, according to the Johns Hopkins Coronavirus Resource Center, which is the preeminent source on these matters, for the US, it's about 1.1%. So that means about 11 per 1,000 people who got COVID died of COVID. Mm-hmm. Is that high? Is that low? Compared to other countries, it's not high, but it's not very low either. So I think we did quite well on this metric. There are countries like Bulgaria, where I was born, where the numbers are much worse. But we did well on this metric. I think that's a testimony to the quality of our healthcare system and how good our doctors are and how good our hospitals are, and how fast we learned. It's also a testimony to the success of the vaccination campaign here, which really helped save lives, especially in the second part of the pandemic. Mm-hmm. So according to that number, we did well, I would say, compared to everyone else. Then there's another number that's also instructive, and that's how many people died per 100,000 of the population. So you take everyone in the US and you say, hey, looking at everybody in this population, all the people here, how many people died of COVID per 100,000? And there we didn't do so well. We have 341 deaths per 100,000 people in the US. And that puts us very much in the top part of the distribution. We're not as high as Bulgaria or Peru, but we are somewhere between Romania and Slovakia. Definitely higher mortality per 100,000 than places like Spain or Italy, who were really the first victims of the pandemic. Everybody was hearing about how horrible things were there. Yes. In March and April of 2020. We did way worse than them. Now, what's the difference between these two numbers? Well, that second number that I told you speaks much more to how many people ended up being infected with COVID. So we had higher numbers of infected people compared to other countries. And despite the fact that we did better in our healthcare provision than many other places, we still had a lot of deaths per 100,000 because of how many people ended up getting COVID. So I think that number is what people are still arguing about. Could we have brought that number down? Mm-hmm. Now, a lot of this has to do with reporting. And so one thing that we did really well, I think, is testing. The US did a fantastic job of having people tested, people self-tested, they reported things. So some of these numbers are, the international comparisons are very much affected by who's testing, how much they're testing, who's reporting, what they're reporting. Numbers coming out of some countries are less reliable than other countries, but we did well on testing, and that may be inflating some of our numbers, but I don't think it's inflating our deaths per 100,000.
Understood. So you're really underlining the international status of these diseases and how they travel around the world, and they're traveling around the world more frequently, I guess, because we're all a lot more interconnected and traveling a lot more across boundaries.
Absolutely. We are one world. People move around much more than they did before. We did have the Spanish flu pandemic of 1918, which had incredibly high mortality rates, and it left a scar, so to say, on people for a
Yes.
generation after that. But what we have now, compared to the amount of mobility we had then, is just incomparable. We're much more mobile, but also with climate change, we are seeing, I think everybody is predicting, the scientists are saying we're going to be seeing many more of these pandemics and viruses going in directions where they can infect humans and multiplying and evolving in ways that probably would have been slower in the past.
Do we know what the connections are between climate change and disease spread? Do we understand that?
My understanding from reading some of the literature is that as temperatures rise, we have a lot more animals, and all living beings are exposed to different conditions. And of course, viruses and bacteria are living beings.
Yes.
And so they evolve in different ways and probably evolve faster. And now we have populations of birds, animals going to places where they didn't used to go before, so they can come in contact with other populations in which they would not have come in contact before. And we have a lot of contact also between domestic animals and wild animals, which is what the bird flu seems to be coming through. That's the vector of transmission.
So let's talk a little bit about your recent paper, and that focused on how stay-at-home orders in one county affected behaviors in neighboring counties. So what did we learn about these crossover effects between communities?
Let me back up a little bit and say that the way we thought about that paper, it was inspired by the debate around how we should implement policies intended to contain the spread of COVID.
Okay.
And there was, as you mentioned in the introduction, there was a lot of comments, a lot of policy debate on how things should be done. Places like China completely shut down everything. Nobody was allowed to come out of their houses. In Spain, they had quite draconian measures. Pets were allowed outside, but no children. People were very upset about this. And then at the same time, in Sweden, they took the other side of the other extreme, which is they basically locked down nursing homes, and older people were discouraged from going out, but they wanted to build what we call herd immunity among younger people who were less likely to experience complications and mortality from COVID. So in the US, the debate was about, should we have a national shutdown? So should the federal government somehow, I don't even know how, implement stay-at-home orders of the type that happened in Spain and Italy? A lot of the way we experienced this, the way it was done here, it was very local. So individual local governments would decide that they would shut down, or what kind of restrictions they would implement. So I remember San Francisco was very early. They had stay-at-home orders. The bigger cities, New York City also had relatively early stay-at-home orders, which is rational and of course understandable because of the rate of transmission in very crowded places. But then we had entire states that never actually shut down, never had stay-at-home orders. So the debate really was about, is that a good thing? Is that a bad thing? How should we do it? And so we took mobility data. Our main question was, well, how do people respond to these orders? Are they actually, some were arguing that if we shut down our county, all that's going to happen is people are going to go in the neighboring county and party there, or go to the restaurants there. So we're going to hurt our economy by shutting down, but the neighboring county is going to be booming because everyone's going to take their business to the neighboring county. And of course, then the argument is, well, we're shutting down because supposedly we have a higher rate of COVID. Now that COVID is going to be exported into the next county. So we will have this, what we would call negative spillover. So we are shutting down, all of our bad stuff is going in the neighboring county because they're not shutting down. So what we wanted to ask was, well, how do people actually behave? Let's look at the data and see what is it that people are doing. And we got mobility data from SafeGraph. They were gracious enough to provide a lot of data resources for researchers at that time. They trace anonymized cell phone traffic across time and distances. And we linked we looked at where people reside. They told us where's the home location of these IDs. We didn't know, obviously, who these people were. And we looked at how people changed their mobility patterns after the implementation of stay-at-home orders. And our question really, we were completely agnostic. We were just wondering, well, what are they doing? Are they staying at home? Are they moving to the other county? What is happening? And what we found was that, in fact, we have what we call positive spillovers in this case, which is when a county implements a stay-at-home order, not only are those counties' residents not going or going someplace, but going at a much lower rate, but the neighboring counties are also slowing down, and their mobility goes down as well in response to the first county's stay-at-home orders. So we found that, well, people are rational and they understand that if there is a lot of COVID in the next door county, it's coming our way too. So we should self-restrain and sort of, implement these measures, even if they are not official yet. But it's in our best interest to limit our mobility, so to protect ourselves.
So that must correspond somehow with the communications in a particular area. Let's say a DMA or direct marketing association, right? So, or direct marketing area. So where there's a TV station, let's say, and they're reporting about a close down in one county, I guess people in neighboring counties are hearing about that from the same source. Is that how it works?
That is exactly right. And you're going in the direction that we discovered about mechanisms, which is that this phenomenon that we found on average was driven by places that had similar, that were basically listening to the same TV stations. So the way we hypothesize this is that, people would hear that, well, County A is shutting down because they have a stay-at-home order, and people in County B would be like hearing this on their evening news and thinking, oh, wow, we should probably limit our mobility because County A is shutting down. So something's going on in our area. Let's just, take it easy and not go party or go to too many restaurants or anything else outside the house.
So it really was that people were following media and doing their best to keep themselves safe, is what I'm hearing.
Yes, people are rational. They do the right thing for themselves. I think what we learned is that people understood the importance of limiting mobility. I think that comes through. And so once they got the information that something was happening close by, they could make their own decisions, and they made the right decisions to limit their own exposure.
Got it. So when we go back to how governments handled things, do we know enough to make recommendations on how governments should handle stay-at-home orders when the next pandemic occurs? Because it will come. It's just a question of timing. Do we know more about how governments should react?
Our results allowed us to make some conclusions and recommendations. So what we can say is that the first best solution to limit mobility is to shut down everything early. So close the whole country early in the pandemic, and then mobility is going to go down by the largest amount. However, it is better to do staggered implementation of stay-at-home orders, which is what we did in this country, than to shut down late. So if we take our staggered implementation and the spillovers that ensue from that, if in the presence of spillover, which is what we find, people self-restrain, they do the right thing. The takeaway here is that if you can, you should shut everything down very early. But in the case of the United States, very big country, lots of local differences. The pandemic took a long time to go through different parts of the country here. So it's hard to argue that everyone should just drop their lives and do nothing. If there is something going on in one part of the country, but there's really nothing going on in another part of the country. What we found is that the way things were done, in fact, was better than shutting everything down, but later.
So you said for the COVID pandemic, and you're just repeating it now, that the United States did a very good job of reporting statistics, right?
Overall, yes, we could definitely do much better on certain dimensions.
Can you tell us, are there steps we can take now to prevent the next pandemic before it occurs?
The best thing we could do is we could spend money on, well, several things. Prevention, which is tracking what's out there. So it's pretty obvious that bird flu is something that it's being reported, we're tracking it, we're watching it. But the
Yes.
more resources, the more scientists we have looking at the virus and how it mutates and what's going on, the better chance we have at preventing pandemic that will be, or more accurately, I think would be to say to prevent really negative outcomes from a pandemic. And that can happen through vaccinations.
Mm-hmm.
So if we could make a vaccine or a blueprint for a vaccine against bird flu, and that's something that I think there's already some work on that, that will really help a lot because that's what helped with the COVID pandemic.
Mm-hmm.
Yes, I think stay-at-home orders would be really the last resort when it comes to managing these kinds of things. Schools have been shut down because there's lots of flu going around. The doctors would come and they'd say, everybody goes home. We have reached the threshold cases from your school, and that's it. You have 2 days of flu vacation.
Mm-hmm.
But we don't want to be at the point where we have to be shutting down entire counties and states, or God forbid, the whole country, because something really bad is going on.
Right. What are the directions of some of your next research? The research you've completed already, I'm sure, is not done completely, and it raises new questions. So what other areas are you pursuing in terms of looking at data and doing research?
Doing quite a lot of different things. In terms of the COVID pandemic, quite excited about how COVID has affected our take-up of disability insurance. We do know that, a lot of people are suffering to this day from the effects of long COVID, complications of all kinds of symptoms that are being investigated and studied by medical professionals as we speak. And so what we're looking at is the correlations between COVID infections and the take-up of Social Security disability insurance in different populations, and also as it correlates with what kind of policies were implemented, where were there shutdowns, when they happened, and so on. And so that's a very exciting and interesting angle, which also links quite neatly to spending and what we spend on. And we do spend a lot on disability insurance. And if shutting down a county earlier would have prevented people from getting long COVID and then having to pay extra in Social Security disability insurance, then that's something that we probably should learn about.
Mm-hmm.
So, we spend here or we spend there, we end up paying for things, but the question is what we pay for and whether we can pay for something to be prevented rather than addressed after the fact when things are already pretty bad and have become chronic. And I think the results of that are going to have pretty serious policy implications as well.
Great. And when you do this research, do you make recommendations to what level of government, or what happens with the research?
That's a great question. Thanks for asking that. And thanks for having me, because I think talking to people like you and journalists and influencers is how we can get our research to gain traction in the real world. I think as a research community, we can definitely do better at disseminating the important findings of our research and sort of synthesizing things and making them easier to understand. The best way for us to speak to the public in general and to policymakers is to talk to people like you. In a way, it forces us to synthesize, digest things, and say them in a way that is understandable to everybody, and also to really think about what are the implications of our findings. But in the end of the day, we do this because we want to help people in one way or another. And so that's where you come in. And thanks once again for having me.
Yes, this is really our goal is to get information out to the public and also promote the work of people like you so that we can all be best informed about how to act and how to stay healthy. We've been talking with Emilia Simeonova, PhD. She's a professor at Johns Hopkins Carey Business School, and you can learn more about her work at her website, which is emiliasimeonova.com, and I'll spell that. It's Emilia, that's Amelia, and then Simeonova is Simeonova. Emilia Simeonova. Emilia, thanks so much for being with us today and sharing this information with us. And feel free to reach out to us to share more information when you have more.
Thanks, Jonathan. It's been a pleasure. Thanks a lot.
Good. My pleasure. And remember, as we say to everybody at the end of every show, go to health. Take care. We'll see you again next time. Bye-bye.
Thank you. Bye-bye. Bye.
Thank you for tuning in this week to Go to Health Media. Be sure to join Jonathan Marks and another health expert next time. You can also catch the program on your favorite podcast platform. Until our next show, be sure to visit us on the web at gotohealthmedia.com and elevate your life.